Okay, good morning, class. Um, okay, so we are talking about female sterilization today. Sterilization means permanent method of contraception, and be it male sterilization or female sterilization, these both are considered as a permanent one. And in today's class, we'll be discussing about the sterilization procedures in female. So as I said, it is a permanent procedure, and there might be some surgical complications and failures which need to be managed further. And this procedure, it does not have any effect on couple life or daily to daily activity. And yes, it is not protective against STDs or HIV. And though it is considered as permanent, reversal is possible, but the surgery becomes a measure and the success rate is not high. Well, the method is the most popular terminal contraception all over the world, and it is also known as bilateral tubal ligation or BTL. In short form, we address it as BTL, bilateral tubal ligation. The indications for these tubal ligation is number one, family planning purpose, which is the most common one, and socioeconomic means it is accepted. The couple who does not require, who does not need more children, they adapt to this procedure, and sometimes medico surgically also the procedure is required. For example, if a lady has chronic hypertension or diabetes, chronic renal disease, cardiac disease, and if pregnancy and the outcomes of the pregnancy are hazardous or harmful to her life, then it is advised to her not to be pregnant. And for that, permanent method is um, advised, that is BTL, bilateral tubal ligation, that can be done during cesarean section also. Now, when does this operation, like when this option can be done? During puerperium. During puerperium means immediately after delivery, say within 24 to 48 hours or up to 7 days of the delivery, it can be performed. Interval. Interval means after 12 weeks of the delivery, means in non-pregnant state, and it is advisable to perform the operation at the follicular phase of the menstruation by the 7th day of the menstruation, or it can be done concurrent with medical termination of pregnancy at the same time, or following spontaneous abortion also. Now the method of sterilization. So occlusion by resection of a segment of both the tube is done. That is called tubectomy. As I said, bilateral tubal ligation is also said, which is widely accepted procedure. And currently, the occlusion of the tubes with rings or clips or electrocoagulation using a laparoscope is gaining popularity. So this is bit advanced where nowadays it is performed because there are chances of less scar. Cosmetically also it looks good. Patient can be discharged earlier. So because of many advantages, but there are few disadvantages also. We'll be talking about that later. Uh, so it is said that the procedure should be delayed uh, in these certain conditions, like if we are suspecting pregnancy in the lady, if she is at a duration more than 7 but less than 42 days of delivery, if there is presence of active pelvic infection or peritonitis. So in the presence of active pelvic infection or peritonitis, we do not perform any kind of pelvic surgery. And even PID within 3 months, because there are chances of having adhesions inside. So it will cause problem in opening the abdomen and exploring inside, or even it is difficult to visualize the tube and deliver the tube. That's why it is not advisable to perform the surgery if the patient gives the history of PID within 3 months. If there is active STD, sexually transmitted disease is there, if she has some active liver or gallbladder disease, because in that condition also there will be problem in giving anesthesia, drugs for anesthesia. If she has any cerebrovascular or coronary artery disease, any complicated heart disease, complicated, where giving anesthesia would be like more dangerous to the life of the patient, then also we do not consider doing it immediately. If she has got severe anemia, so anemia should be corrected first, and then the procedure is delayed till her hemoglobin reaches to normal level. If she has got psychiatric disorder, um, because we do not know in what state of mind she gives the consent for the surgery. So if she is not stable psychologically or in psychiatric point of view, we it's better to delay the procedure. And yes, if she has undergone several laparotomies before, then we should delay the procedure again because of the fear of having dense and dense adhesions inside the abdomen, because it will create problem in the visualization of the tube. So in order to perform the surgery, there are certain requirements which the surgeon should keep in mind. First of all, the bladder should be empty. Okay, the bladder of the patient should be empty. Uh, and while operating, the fallopian tube should be identified up to fimbria. Okay, up to fimbria. And when occlusion is being done, it should include at least 2 to 3 centimeter from uh, cornu and in isthmus area. So you have to um, remember a bit of anatomy here, anatomy of the fallopian tube. Excision of 1 centimeter of tube is done, and it should not be crushed. We'll be talking about few techniques. And one of the techniques, there is a crushing of the um, crushing of the tube. So um, that has been abundant nowadays. So it is advised not to crush the tube, and probably because of high chances of recanalization. And if the tube is incised, or even if it has been cut, the um, ligation is done by either absorbable or non-absorbable suture. So these are the surgical techniques. Surgery can be performed abdominally or vaginally. If we are performing abdominal, then either we can give a conventional incision, conventional one, or mini laparotomy, where a small incision is given, tube is delivered through the small opening, or laparoscopically. So whether we do conventional or mini laparotomy, there are the techniques of ligating the tube. So what are those different techniques? Pomeroy's, or nowadays modified Pomeroy's is also said, modified Pomeroy's method, which does Irving's, Madelner, Ruener, Oxford, Eltrees, and more is there. Parkland method is also there. We'll be talking about it. So these are the different methods of ligating or cutting the tube, like creating occlusion in the fallopian tube. So if abdominal is being performed in conventional steps, first of all, patient is anesthetized, and in anesthesia, we can either give spinal anesthesia or the general. Even it can be done under local anesthesia also. And if the procedure femoral sterilization is being done in the camp basis and mass camp basis, and then better to give local anesthesia. So there are a number of benefits of giving local anesthesia. Patient can be discharged almost within 4 hours of the procedure. Um, Patient does not need hospitalization. So after giving anesthesia, incision is given. So if the procedure is done in porphyrium case, the uterus is palpable, like this palpable in abdomen. Okay, so incision can be given just 2 fingers below the fundus of the uterus if it is being done in porphyrium case. Um, if it is done, like if interval one is done or non-pregnant, then incision is given 2 fingers above the pubis symphysis. And after giving the incision, tube is delivered. So, uh, and then different, by applying different methods and techniques, tube is occluded. So we'll be talking about the first, the most common one. Practically nowadays we do modified Pomeroy's method. Okay, so you can see in the picture A. Okay, see that the fallopian tube is being held by one instrument, and that instrument is called Babcock's forceps. Okay, that Babcock's forceps, it is holding the tube uh, in such a way that it includes ampulla and isthmus. That the loop it makes, it includes ampulla and isthmus. And what we can see in picture B, a tie is made around the tube, giving it a shape of a loop. So while making a tie, a needle is inserted through major salpinx by seeing which area is a vascular one. So it should be done very carefully so that we do not prick any vascular area, otherwise it will bleed profusely and it is quite difficult to control that bleeding. So we choose a vascular area of major salpinx, needle is passed through it, and a tie is made loop is made and it is tied firmly. Then that particular segment is cut, around 1 to 1.5 centimeter of the segment. Distal to the ligature, it is excised. And the intact tube is left adjacent to the uterus. It's that specimen is sent for histology, which is not done routinely. Only in some cases, if we suspect any pathology, then only we send the specimen. Otherwise, it is not required in every case. So that is the modified Pomeroy's method. And secondly, the method is Uchida. So in Uchida method, you can see in picture A, something is being injected into the isthmus and the subserosa. So saline is injected, giving it the appearance of a bleb. And incision is given on the serosa, and muscular portion is identified, and that muscular portion particularly is divided, and the serosa is dissected bluntly, and muscular portion is ligated and then dissected. And what is done with the remaining portion is the proximal portion is buried into the mesosalpinx, and the distal one is kept open to the peritoneal cavity. So this is the Irving method. You can see in the first picture, a hole is being made in the broad ligament, and two separate ties are made. Okay, two ties are being made in the tube, and then the portion is cut, and the both ends are being inserted into the posterior uterine wall. So this is the method where the failure rate is um, very low. On like almost there is no failure rate. In Parkland method also, you can see more or less it looks like Pomeroy's method. In Madelner's procedure or technique, Madelner's technique, the crushing of the tube is done, which is not recommended these days. And femorectomy means cutting of the femora, and the procedure is known as Groener's method. And this nowadays Groener's method is also not done. Most commonly done is Pomeroy's method, modified Pomeroy's method. So as I said, Irving method has a very less failure rate as compared to other methods. Laparoscopic we'll be talking. So in this conventional or in many laparotomy cases, the complications could be anesthetic hazard. There are chances of injuring bowel and bladder, uh, and where the opening is made in the broad ligament, chances of creating hematoma there. Infection can be there as in other surgeries, wound sepsis, even peritonitis. So these are the rare complications actually. Hysteroscopically, also it can be performed. By using hysteroscope, nowadays it is also gaining popularity. So in the picture, can you see that coil-like thing is known as a sewer, and it is inserted inside the uterus, and the larger outer coils is placed in the uterine part, and uh, this is micro insert. Okay, so gradually it has let's say that reaches the uterotubal junction. So after doing this procedure, HSC, histosalpingogram, is performed to confirm the occlusion. So when the dye is inserted into the uterus, it does not come out of the femoral end. So in the X-ray, it is visible that both the tubes have been occluded after performing this procedure. So discussed about abdominal conventional laparotomy, or now talking about laparoscopic sterilization. In the laparoscopic, laparoscopy is used only. Um, Ports are made, and needle is inserted after creating um, pneumoperitoneum by carbon dioxide. So basic thing is same. Okay, and advantages are also we can visualize it directly. So manipulation can also be done directly, and the other surrounding can be visualized. So if there is any abnormality, pelvic or abdominal abnormality is there, then it can be picked up. Hospitalization is not required. It has cosmetic advantage, and the post-op pain and discomfort is minimal. And when the clip is applied, then reversibility is more. So as long as clip is there in the tube, which is applied laparoscopically, when the clip is applied, um, it gives the contraceptive advantage. But when that advantage is, say, no more demanded by the patient, or if the couple decides to have children again, then clip can be taken out. So reversibility is more. So the patient is okay, so the surgery is performed laparoscopically. You can see the picture gives the more or less idea. Okay, laparoscopically, we can either insert a ring, or we can apply clips, or even electrocoagulation can be done. So in the first picture, you can see clip is being applied to the tube, making it a loop. In the second picture, clip is applied to the tube. So the name of the ring is also rhythmic to the fallopian tube. Fallop ring. This is a silicone rubber that contains barium sulfate. The clips which are available are PLC clips, which is again silicone, and it is considered to be the better one as compared to the another Halka Clemens clip, which is spring loaded. So you can see the picture of clip here. Now the complications of the ligation performed laparoscopically. Again, since anesthesia is required here too, there can be anesthetic hazard. In spite of directly visualization of the structures, there are chances of injury to the large vessels. While inserting the trocar, it can injure epigastric vessels, causing diffuse bleeding from it. Major selfings can be drawn. There can be bowel injury, there can be burns, risk of surgical and mediastinal emphysema is there. Okay, so those were all done. Mm, Laparotomy and laparoscopically done abdominally, okay, and hysteroscope, though the hysteroscope is inserted through the vagina into the uterus, vessel cavity is not not incised, okay, but in vaginal tubal ligation, colpotomy is performed, and incision is given in the posterior fornix, and tube is delivered, and ligation can be done. In complications also, bowel injury, pelvic abscess can be there. So it is not commonly performed. Books though mention about this posture, not done these days. And yes, tubal ligation, it can be done during cesarean section also, like in repeat cesarean section. Like if somebody has already undergone cesarean section for 2 or 3 times, then with proper consent, and if the first child is more than 5 year old, then we advise her to go for BTL, bilateral tubal ligation, and only after taking the consent, we perform the procedure. So this is probably the last slide. Mm. So after sterilization, okay, what other effects it can occur in the um, reproductive uh, system or um, something else? It can lead to ectopic pregnancy. For example, after tubal ligation, accidentally, if partial recanalization occur, or tuberculosis fistula happen to um, occur, then there can be fertilization. Okay, and the fertilized ovum can get stuck into the remaining portion of the tube, and as it gains larger size, it cannot pass through the tube to come into the uterine cavity, endometrium, for implantation. So when it gets stuck in the tube, it gives rise to ectopic pregnancy. And it is more likely after 3 years because the duration for the recanalization is being considered. during that 3 years. Now, another common symptom patient comes with after getting tubes ligated is post-tubal ligation syndrome. There can be abnormal bleeding or more commonly menorrhagia. Patient comes with menorrhagia after tubal ligation and pain abdomen. So it is said syndrome. Okay, there are more symptoms, bleeding and pain abdomen. Sometimes there can be decreased bleeding or irregular bleeding. And yes, after doing BTL, if anything happens to living children, or if she gets separated with her partner, and if she gets, let's say, if um, she goes into the marital status with another man, and there may be conditions where baby is required. So in that condition, when recanalization is not possible or has very less chances, and that the procedure becomes only one of the ways for the regret, and the patient may go into the depression for it. So while performing this surgery, we should not forget that this is a permanent one. So we are like closing the doors for her to have further children. So the advice should be given very carefully. We should not advise randomly to any multi-para to go through the tubal ligation. We must make sure whether the child is having at home is um, fit physically and mentally, and the age of the child should also be considered. And with proper counseling, with mutual consent of the partners, okay, uh, it is advisable for the surgeon to individualize the case and not to perform the surgery in any random patient. So this one, a sequelae of sterilization is important in the point of view that the patient, practically patient comes to you with these complaints, with if this she can present to you with the ectopic pregnancy, she can come with you for this post-tubal ligation syndrome. So practically, it is important to know that these are the results really of the sterilization. So history of contraceptive is quite important when you take history in of gynec or obstetric case. So you'll be asked to write about the different methods of these mm, um, different techniques of the tubal ligation. So if you do not know the details of every procedure, then you must be able to explain Pomeroy's method, at least Pomeroy's method, because practically it is done. Okay, and others you should at least remember the name. And the time of operation is also important. So that is all about this topic. Very short topic. Okay, it won't take much time for you to revise whatever is given in the book. I've tried to cover almost everything, but if there's